afternoon, ladies and gentlemen. This is going to be a very clear and straightforward clinical talk because the concept of brain protection from the expectation that we would be able to develop brain protective drugs or even drug cocktails totally failed after 40 years of research. So while in the past we perceived and understood brain protection again as compounds that we would give and that would render the brain robust when it comes to traumatic or ischemic damages, acute neurodegeneration has moved into, I think, a paradigm, a concept along homeostasiology, I may want to call it. Why do I strongly believe that perioperative medicine and anesthesiology in particular should deal with brain protective concepts more than ever before? It's because there is so many devastating acute neurodegenerative entities available in the perioperative period, such as the fact that we are exposed to patients in the order of 50 to 70 in a population of 100,000 that suffer from a preclinical cardiac arrest and in this or that way get exposed to anesthesiology. 150 patients in a population of 100,000 suffer from ischemic or hemorrhagic stroke. And then there is well-reported visible overt stroke rate of up to 0.8%, which is very high. Almost one patient in 100 patients that suffers from perioperative visible stroke. Totally unacceptable in the cardiac world. We would never accept that. That's reality. But what was very, very irritating, much more irritating, was a publication by last year that looked for covert stroke. So that is a stroke that has no obvious, no explicit symptoms, maybe implicit symptoms. What they did is MRI studies in the first week from elective surgery, and this was non-vascular, non-cardiac surgery. It was bowel surgery, it was hip replacement, and there was this is not a typo, 10% stroke in just a normal surgical population, totally irritating. Then 30% neurological deficits that would occur after subarachnoid hemorrhage. Head injury pretty much is a cerebral ischemia model, and the rates for cognitive dysfunction following cardiac surgery or arthroplasty, because there's a high embolic shower that apparently occurs with knee or hip replacement, varies between 20 to 50% depending on the study that you read. And again, this is not available has no sensitivity to drugs. We need to change the concept of brain protection more into managing homeostasis. And because of that, I would like to stress again and again this concept of primary and secondary injury, which is true for the resuscitated brain, the traumatized brain, the ischemic brain, and. So please accept this as an example, conceptualized example for what is going on. And there is only prevention that could reduce primary insult. Airbag system, belts, working protection, less violence, etc., less stroke, because the primary insult is what really immediately traumatizes neurons. It's the colliquation, it's the laceration, it's the physical insult, the impact that just aggressively, brutally destroys brain. But in the aftermath of this primary insult, several physiological derangements occur, which are exactly the root for the paradigm of homeostasiology, brain protection, which is the occurrence of hypoxia, of arterial hypotension, of hypercapnia, but also hypocapnia, hyperglycemia, and hypothermia. All of these factors have been precisely identified as cofactors for what then occurs as secondary growth. So if we will be able to manage these physiological factors, and who, if not anesthesiology and critical care medicine, then we will be able to reduce the secondary growth of injury and hopefully make patients return into their families, the school, kindergarten, or work. And so along those factors, this is the concept or the outline of my talk. I will, because the talk was called Brain Protection During Anesthesia, I will devote quite some time on describing the effects of anesthetic agents. We will then discuss cerebral perfusion pressure, fluid management, ventilation, glucose and temperature management, and ultimately, although I stated there is nothing, some few words about neuroprotective drugs. Let's start with anesthetic agents. Here we go. This is a cartoon that I drew motivated by an idea from Piyush Patel from the University of San Diego in California. And this is 40 years, maybe 50 years of dog, rat, gerbil, mice, and so forth, goat research on brain ischemia. And every single study, I would think, every single valid, better study, I would think, that has investigated the brain protective effects of barbiturates, propofol, or inhalational anesthetics show that if you have a mild ischemic insult in animals and the drugs are on board prior to the insult, you can profoundly improve outcome in reducing infarct size or improving functional outcome of the animals. Barbiturates up to 80%, propofol up to 70%, and so forth. So this is just eyeballing data and drawing it roughly as a bar graph, but pretty much there is little doubt that in rats and animals, if the insult is not severe and the anesthetic is on board prior to the insult, you can profoundly improve histopathological and functional outcome. But there is zero evidence in humans. There's a complete translational loss of this profound evidence. And the reason for that is that most of those studies suffered from statistical power, inadequate models, improper management of physiological variables during those studies, study bias, poor statistics. And so that is the major reason why the translational loss unfortunately occur. Several studies have made an attempt to demonstrate brain protection from anesthetics in humans. For example, during anesthesia for carotid surgery. And obviously here you can compare general anesthesia with local regional anesthesia. And in the first years between 1989 and 2006, there were 7 smaller studies available that have compared local anesthesia with general anesthesia for carotid surgery. And there was no clear result. And then the GALA trial was initiated, investigating more than 4,000 patients. Pretty large, actually very large trial. I would not be able to pull that off. And the GALA trial seemed, with not ideal confidence intervals yet, it seemed, or it suggested, and that was the conclusion, and it was worldwide accepted, that probably local anesthesia is better for those patients compared to general anesthesia, despite the fact that I did show you that in animals, anesthetic agents protect when they're on board prior to cross-clamping a vessel that, and then depriving the brain from blood. But the GALA trial suggested it favors local anesthesia, and if you added the GALA trial in this meta-analysis to the 7 previous smaller investigations, then favoring local anesthesia became even more clear. But again, even that particular study was criticized by experts for still a sample size being too small, for the fact that regional anesthesia was unfortunately not standardized among the participating centers, as was not standardized the use of supporting catecholamines for hemodynamic instability. And I think most critical is the fact that while in the awake patient you have a neurological monitoring because he/her is awake during carotid cross-clamping, you can see whether you need to shunt or not. In the general anesthesia patient, that clinical access is not available unless you use neuromonitoring. But neuromonitoring was only sporadically used in those studies in the general anesthesia population. And I think that's the major drawback. So I don't think that this trial really proves that general anesthesia is worse than local anesthesia. What it proves is that you need neuromonitoring, be it clinical or electrophysiological monitoring. And as a cofactor, it seemed that in the awake group there was more myocardial infarction, likely because those patients were stressed. Very recent studies, not primarily trying to prove that anesthetics protect or don't protect, but observing towards that direction, are studies where you compare general anesthesia or sedation awake or sedative sedation in patients that are subjected to endovascular thrombectomy for stroke treatment. The studies for thrombectomy are very convincing. A lot of studies now available. This is the next big step after the 90s when Werner from Heidelberg introduced the lysis concept, and that was a big step. But this now is a totally different world, and outcome is so much better in many patients, something that was not readily available 10 years ago. It's just super. Now the question is, can we escort? Can we be an escort here with a proper sedative or anesthesia protocol? And in this meta-analysis of 7 trials in about 1,700 patients, with the endpoint of modified Rankin scale at 3 months from thrombectomy, data clearly show that standard care, which is no thrombectomy, is bad when compared to thrombectomy. But the data also show that thrombectomy in general anesthesia is not as good in terms of the outcome 90 days modified Rankin scale when compared to those patients that received sedation or even no sedation. So again, as anesthesiologists, something we would like to have, anesthetics protect, it is just not proven. Why? Well, actually, we don't really know. There was hypothesis that the use or the induction of general anesthesia takes longer, and therefore the allocation time from symptom onset to removal of the clot is just longer. And that is because studies suggest so. If you have, this is again the modified Rankin scale, as a function of time from onset of the symptom to the expected arterial line puncture, you have a loss of 6% brain every hour. So you don't want to stay and play, you would want to scoop and run. And again, there was it was inferred that probably the induction of general anesthesia takes longer to be established when compared to awake, and then you would lose brain. So time matters, and time matters. Very clear as stated from this meta-analysis from 5 randomized controlled trials. But let me return to this 2018 study from Lancet Neurology. In that study, where awake or light sedation was better than general anesthesia, there was no difference in time from onset of symptoms to removal of the clot. So this study cannot be explained by time. So bottom line, we fail to show anesthetic neuroprotection in those studies that had made a translational attempt. I'd like to stay with anesthetic agents and characterize now cerebrovascular dynamics, because that matters in terms of management of intracranial pressure. And so this is supposed to be the baseline tone of a cross-sectional area of a brain artery. And I would like to show you now, and you all know this, what happens if you give intravenous anesthetics. They all vasoconstrict. They do so because they reduce cerebral metabolism. They reduce functional, but not basal metabolism. But the reduction in functional metabolism, we've seen studies from Michael Alkire and other work. We've seen the result of anesthetic agents on the EEG. Both of this creates vasoconstriction in a dose-dependent fashion and in a drug-dependent fashion. Dex vasoconstricts, but to a lesser extent compared to propofol, to a lesser extent than the barbiturates. And this vasoconstriction that I've illustrated here with this primitive cartoon is the reason why any of those drugs, barbiturates more than propofol and propofol more than dexmedetomidine, are available for vasoconstriction during brain bulk. You can reduce, you with this vasoconstriction, you reduce intracranial blood volume and in turn intracranial pressure if intraoperatively or as a function of ICP crisis on the ICU necessary. How would this look with the use of inhalational anesthetics? Again, this should be a % change from baseline tone. This cartoon should be the cross-sectional area of an artery and baseline tone. And as we add sevoflurane or isoflurane or desflurane, you have again a dose-dependent and drug-specific change in vascular diameter in terms of vasodilation. And the data clearly show, and that is human data now finally, that sevoflurane at least to 1 mg has the least vascular effects, while isoflurane and definitely desflurane is a very potent cerebral vasodilator. And this vasodilation, dose-dependently, drug-specifically, translates into increasing blood volume in the skull and in turn increases ICP. And I'd like to expose you to the fact that if anyone ever still uses nitrous oxide, the addition of nitrous oxide creates a hyper vasodilation with a lot of increase in brain bulk. And please realize and understand that in this situation, even hyperventilation cannot make the vasculature return to baseline tone. So that is, all of this is a profound vasodilator, and again, that translates in a talk on brain protection into brain bulk potentially, so you may want to select your anesthetics according to the intracranial compliance, or I should better say, the intracranial resistance. This vasoactive effects now make me discuss in one slide the question of whether or not anesthetic agents inhibit or abolish or impair cerebral blood flow autoregulation. Remember, autoregulation refers to the fact that cerebral blood flow maintains constant over a wide range of cerebral perfusion pressure in vasoconstricting, again, accept these little cartoons as vascular cross-sectional areas of vessels. If you have an increase in perfusion pressure, you have vasoconstriction to maintain blood flow constant. If you have a decrease in perfusion pressure, you have vasodilation. And if you exhaust this mechanism, then there will be a pressure passive increase in vascular diameter if the mechanism is exhausted as perfusion pressure increases further, and you will have a collapse of the vessels as perfusion pressure drops below the maximum vasodilatory potential of the vessel. So this is the normal situation. And it was always said that volatile anesthetic agents, because they are profound vasodilators, abolish or at least impair autoregulation. I don't think that is true. It's just a reset along a different line. Even with volatile anesthetic agents, autoregulation is maintained, yet on a very much higher level. But even in the presence of an anesthetic, volatile anesthetic, as you increase cerebral perfusion pressure, it is still available for vasoconstriction and to control for constant blood flow. And for the hypnotic agents, it was always accepted that they are believed to maintain cerebral blood flow autoregulation. So I propose, beyond considering brain blood volume and ICP, I don't think it is valid to further propose that volatile anesthetic agents impair cerebral blood flow autoregulation. It's just a reset along a different line. And as we talk about autoregulation, we need to talk about, and now we're leaving the sector of anesthetics, cerebral perfusion pressure, obviously a clinical number that relates to the difference between blood pressure that drives oxygen and glucose into the brain, and the force that tries to emit that, which is intracranial pressure. So as we talk about perfusion pressure, it is important to understand that if you want to manipulate perfusion pressure in a brain protective concept or in a management concept of homeostasis, you can address either blood pressure or ICP or both. And I'll get back to this in very soon. Again, autoregulation is maintained in some patients, and in some patients it isn't. And since even in the most elaborate institutions in the world, I don't think the on-site or bedside intra-OR measurement of blood flow, cerebral blood flow is available, we need to find a compromise in those patients that may or may not be impaired in their ability to control for constant cerebral blood flow. And many, many data from subarachnoid hemorrhage, aneurysm surgery, head injury suggest that those curves across each other are similar, have an overlap within a range of 50 to 70 millimeters of mercury cerebral perfusion pressure. And this is while the Brain Trauma Foundation guidelines, even in its ongoing continuous revision, have stated that this should be the corridor by which patients in a brain protective concept should be managed. If this is exceeded, like you may remember the Rosner concept, who proposed that we need high pressures and a lot of volume to maintain high pressures, blood catecholamine, then ARDS is likely to occur, while obviously as you go below 50 millimeters of mercury, then ischemia is likely to occur. So this is a mix of evidence, but also empiricism and reasoned approach, and stated by the guidelines as a management corridor for perfusion pressure. And this is the slide that I already indicated I will be talking about, and it describes the distinguished approach for managing perfusion pressure, which can be managed by either blood pressure or intracranial pressure or both. And that is why you need to consider, for example, the effects of anesthetic agents on both of those entities, the blood pressure and the intracranial pressure, to learn what the net effect on perfusion pressure would be. It's an Italian study. They have investigated the effects of barbiturate coma to control for intracranial hypertension on intracranial pressure, blood pressure, and ultimately the calculation perfusion pressure. Just look at the intracranial pressure. There is patients, as you provide them with the bolus administration of barbiturate to control for ICP, where you have a real nice, almost 25% decrease in ICP, which you want. Those are the responders. Then there is partial responders. They do respond, but not profoundly. They do decrease their ICP, good thing, but not profoundly. But please note, there is patients where you give barbiturates and ICP goes up. Very irritating. Let's observe now what the effect of barbiturates on blood pressure would be, the second factor that contributes to perfusion pressure. And there you can tell that obviously in a dose-dependent fashion and also depending on the speed of administration, slam-bam versus slow, you have pretty much in every patient a decrease in blood pressure. And that is why you need always to look at both the ICP that should go down, but also the blood pressure that should not go down, because your net effect might be negative. And now if you add those columns in the responders, the partial responders, the non-responders, then you can tell that only group 1, the full responders, would benefit from barbiturates in that they decrease their ICP more than their blood pressure and therefore benefit from a net positive effect on perfusion pressure. While those that decrease ICP and blood pressure to the same extent, that's a net effect. You just have side effects from the barbiturates, but you have no effect on ICP. And those where you have no decrease in ICP but a drop in blood pressure, those you make things really worse. So it's necessary to, in a pharmacodynamic fashion, to approach this with knowledge about the side effects of those compounds and with the proper management of those side effects to benefit for the patient. And that perfusion pressure or blood pressure, let me go back. Blood pressure is just so important. Perfusion, hemodynamics, left ventricular preload, afterload, left ventricular cardiac function, those are the things that we have to consider in terms of neuroprotective paradigms. And I'd like to show this study, which has in the first and second place nothing to do with the brain. But it's a study that I was intrigued by because it is the first study from France, Clermont-Ferrand, which was published last year. The first study that shows that if we go for a meticulous hemodynamic management, here renal function was the primary organ, but it was a composite outcome, and there was also consciousnness of patient. So if you allow for drop in blood pressure, the probability of post-operative organ dysfunction intraoperatively is higher than if you use an individualized treatment where you maintain patient's blood pressure by volume or catecholamine concentration within a range of plus or minus 10% from awake baseline. The study is really, I think, is a great study because, again, it's the first time that a study doesn't only show hypotension is bad, you have organ dysfunction, that a study can show that if you reverse hypotension, be active, be a manager of homeostasis, you can improve outcome. Fantastic. And again, one of the secondary outcome parameters was consciousness, and consciousness was less disturbed in those patients that were fortunate to receive an individualized blood pressure treatment, maintaining it in a corridor of plus or minus 10% from baseline. And as we talk about blood pressure, we need perfusion pressure and management. We need to talk about fluid management, obviously. And it's clear too that while I was brought up with always running patients dry, at least if those were patients with a brain crisis, in expecting that as you run patients dry, you would reduce edema formation. This is no longer true because as you run patients dry, you create hypovolemia and in turn hypotension, and we've now extensively discussed the detrimental effect of hypotension. So clearly the rule of thumb is to maintain normal volemia and to maintain isoosmolarity and certainly avoid hypoosmolarity. And this is the most recent recommendation that is available on perioperative volume management in patients specifically with acute or chronic neurodegeneration, and it says that only isotonic crystalloids are recommended. In the past, which is until 2017, you could find isotonic colloids and hypertonic colloids in this recommended section. Now it's only isotonic colloids, and no more recommended would be, crystalloids. No more recommended would be isotonic colloids, the hypertonic crystalloids and colloids as a standard treatment. We get back to those. And certainly hypoosmolar solutions, free water and glucose, is just not what you want to do. Now, as standard fluid management basically is located within the corridor of isotonic crystalloids, the osmotherapy for elevated ICP, of course, has two instruments available, one of which is mannitol and the other is hypertonic saline. The belief why those drugs reduce ICP is twofold. Number one, because of producing a hyperosmolar gradient that extracts free water from the interstitial brain and spinal cord spaces back into intravascular space and then removes this volume from the brain and the vertebral column, and in turn reducing pressure on neurons. And the second thing that is the second belief why this might be effective or is effective is that you improve rheology because you reduce viscosity in applying osmotherapy, and also this should facilitate at least cerebral venous drainage from the intracranial cavity. And again, those two compounds are available, and it is clearly stated that those compounds should only be used if there is a predefined trigger, that is brain bulk, that you and the neurosurgeon can demonstrate as a visible thing during the operation, or you measure ICP. So you need a predefined trigger, and that should be 20 or 25 millimeters of mercury ICP, or the visibility of brain bulk. And the initiation should only be based on this, the predefined trigger and neuromonitoring or clinical variables, and not just in the morning, one shot, and in the afternoon, one shot. So every shift, one shot. Definitely should not occur. But predefined triggers on the basis of clinical or neuro monitoring. Moving on to ventilation, you may think, brain protection during anesthesia, ventilation? Yes. Believe me, every single statistic, be it retrospective or prospective, for subarachnoid hemorrhage, neuro cases, whatever, shows that still hypoxia occurs. And if it's only because many of those patients suffer from early pneumonia. So hypoxia is present even now in 2018 as of summertime in the Western world, and hypoxia certainly is one of the major cofactors next to hypotension for poor outcome in acute neurodegeneration. So we need to talk about oxygenation and decarboxylation, and it was for a long time believed that the concept of lung protective ventilation does not go well with brain protection. But I don't think this is true. It's not that I think, it has been shown that this is not true. So you can easily apply in the OR and certainly on the ICU concept of lung protective ventilation without doing harm to the brain. And I would like to, beyond this proposal of lung protective ventilation, maintaining this even in acute neurodegeneration situations, I'd like to stress that I'd say normoxemia is what you want to go for. Several studies in resuscitated patients most recently, and also head injured patients after subarachnoid hemorrhage, have made an attempt to investigate hyperoxia or superoxia as something that could improve outcome, but in fact the opposite was closer to the truth, likely because of the generation of free oxygen radicals. And therefore it is believed that the oxygen saturation between SIG 96 to 98 would be okay, and a PaO2 between 100 to 150, but not 300 or 500, and not FiO2 of 1.0. So you may want to orient yourself and find orientation in the range of arterial oxygenation between SIG 96 and 98, something like this. And certainly because lung protective ventilation sometimes causes permissive hypercapnia, that's something you may want to be intolerant about. You need to monitor closely end-tidal CO2, arterial CO2, or whatever you do, and certainly control for minute volume, because lung protective ventilation infers pressure-controlled ventilation, as you well know. And also, if we're talking about the ICU now or OR, you can use kinetic therapy. Those patients may be minimal handling patients, but they deserve 130 degrees or 180 degrees prone position in order to recruit collapsed alveoli. So, because also there was also a dogma that you would not be, those patients, no matter even if they have a condition like this with basal and dys and atelectasis, should not be placed prone because of increases in ICPs. Just if you do it carefully, if the axis of the cranium and the vertebral column is maintained neutral during this maneuver, then there is no way why you should omit or why you should not make this wonderful treatment available to patients with acute neurodegeneration. Brief comment on hyperventilation with elevated ICP, certainly something that reduces neuronal and extracellular acidosis, but more importantly, it reduces, as we said before, cerebral blood volume and in turn ICP by vasoconstriction. And the data very clearly show, this actually is Jonathan Cole's work because we were talking about him last night. The standard will be normal ventilation in the OR and on the ICU. Why? Because as you hyperventilate to reduce ICP, it may work. It actually may work in a lot of patients, but it is always at the expense of brain blood flow. The mechanism by which you reduce ICP is you hyperventilate to vasoconstrict arteries. And this wonderful study from Addenbrookes in Cambridge shows that this is a brain with some ischemic spots, but as you hyperventilate this brain in an attempt to reduce ICP here, you increase the red spots that are indicating ischemic insult. So it needs to be in a distinguished fashion only during ICP crisis or intraoperatively if you and or the surgeon observe cerebral protrusion. Glucose management, Clearly, in this retrospective study in more than 1,000 patients undergoing carotid endarterectomy, it was evident that the operative day glucose was related to outcome. And outcome here was stroke or transitory ischemic attack, mortality or myocardial infarction, a composite outcome that's usually described as major vascular events. And if plasma glucose or blood glucose concentration was in the range of 250 milligram per deciliter, the incidence of those major vascular events was just higher when compared to a slightly hyperglycemic or normal glycemic level. Clearly treat hyperglycemia, but avoid hypoglycemia, because hypoglycemia kills as well. And this is something that started with Gret van der Berge at the Catholic University in Leuven in Belgium, and was then repeated by many, many other great studies like Nice Sugar Trial and so forth, showing that there is a J-curve between mortality and plasma glucose concentration. Hyperglycemia kills, but I'm repeating myself, hypoglycemia kills as well. And in the individualized tight glucose control management that was proposed by Gret van der Berge, it was always evident, and it happened to me multiple times, that as you really attempt in an individual patient to hit 80 to 100 milligrams per deciliter, so strict normal glycemia, tightly controlled, you would overshoot in individual patients your insulin treatment and render them severely hypoglycemic, which kills neurons. And because of that, the current, again, it's not evidence-based, but the current recommendation is to be permissive in a corridor that says between 100 and 130 or 110 to 150 milligram per deciliter. Not because this is considered normal glycemia, of course not, but it's an airbagging that protects, hopefully, most of the patients from overdoing it and getting into a hypoglycemic range. Temperature management, that is interesting. Just for this, for the purpose of this presentation here, did I check the entire literature, starting in 1951 with Dr. Bigelow, who, with that and some other publications in the 50s, laid the ground for hypothermia and application of hypothermia in the OR during cardiopulmonary bypass and aortic surgery. There is pretty much zero evidence based on what we believe that the movement of evidence-based medicine should present to us, zero evidence for cooling during cardiopulmonary bypass, be it during open heart surgery, coronary surgery, or aortic arch surgery. But everybody does it. And when we asked my surgeon, we could not say that's the publication. But probably the only publication, which was not a randomized controlled trial, nothing, it was just a description, was Bigelow. And the rationale by which hypothermia is used to protect neuronal tissue in the event of cross-clamping, cardiopulmonary bypass, stuff like that, has been nicely repeated in this publication here, and these two publications actually. The rationale is just what Emery Brown also told us, that there is here by temperature, in that case it was anesthetics, there is a dose-dependent here, temperature-dependent change in electrical activity, and if you have mild to moderate hypothermia, you have a slowing in EEG, and if you deep hypothermia or profound hypothermia, you may even produce cardiac arrest for 10, 20, 50 minutes and do surgery on giant aneurysms in the brain or the heart or the aorta, and the patient will still pretty plus or minus be the same upon rewarming and recovering from surgery. That's it. So no doubt, hypothermia protects in the surgical setting, aortic surgery, cardiac surgery, with very little evidence, but a reasoned approach following a logical ductus. And why does it do so, and why is it likely better than anesthetics? Because other than anesthetics, it depresses functional and basal metabolism, while anesthetics reduce the functional metabolism until EEG isoelectricity only, without, not that we knew, also reducing the functional, the basal metabolism of the individual neuron. That's it. Then you can also use hypothermia in the preoperative setting if kids suffer from perinatal hypoxia. This is a guideline. There were 3 studies available. Those are these 3 studies, all of which had favorable results. So it is justified to use mild to moderate hypothermia in kids that suffer from severe perinatal hypoxia. But that's it. While we believe that in cardiac and major vascular surgery we do well with or without pumps, we do know that intraoperatively in the OR, in the neurosurgical OR for aneurysm surgery, there is no use for hypothermia, as evidenced by this very good trial many years ago performed by Dr. Todd at 7 international centers, where they randomized patients to normothermia or hypothermia during brain aneurysm surgery, and outcome was absolutely identical no matter whether the patients were cooled or not. Clearly, however, is that if you allow for fever, you will have this profound increase in mortality, in ICU length of stay, and also in hospital length of stay. So clearly, treat fever whenever possible. And now one single desperate slide on neuroprotective drugs. As I said, it's a change in paradigm. There is some residuals of 40 to 50 years of research that had made it in the guidelines, but even those residuals are I would think, shaky. It is recommended to use steroids in pneumococcus meningitis because that is a kind of meningitis with a profound edema formation, much more than other meningitis. And therefore, the steroids have been recommended, of course, in parallel to antibiotic therapy. And also, the perifocal edema is sensitive to steroids and melts away, and headache and dizziness and vomiting and nausea disappears in most patients in the presence of perifocal edema that is then treated with, for example, dexamethasone. Nimodipine, the calcium channel blocker, has been effective only in aneurysmatic subarachnoid hemorrhage, not in traumatic subarachnoid hemorrhage, and it has also been only effective if the compound was administered orally. If you administer it IV, the effect was gone. This study, it was a large trial in England, has been criticized for multiple things, but it is still in the guideline, and every single new revision by the Cochrane analysis and other meta institutions would still leave it in. So if you have a patient with aneurysmatic subarachnoid hemorrhage that suffers from vasospasm and neurofunctional decompensation, oral nimodipine is okay. IV nimodipine not, because you cannot control for the blood pressure. Blood pressure goes down, effect is gone. And then statins, according to this most recent publication from the European Reviews of Medical Pharmacology and Sciences, says if they are on board prior to an event, okay. If they are not on board, don't give them actively. And an incomplete list of maybe 5,000, no, I'm overdoing it, but maybe 1,000 compounds that had been tested in the past and then made it into the clinical settings, such as whatever NMDA receptor antagonist, the endothelin antagonist clazosentan, for example, progesterone, magnesium, large trials on magnesium, and also erythropoietin. They had no effect in humans, and that's what I'm saying. Brain protection exists, but it's a new paradigm. It's homeostasiology. I'm summarizing. That is key. This is key. The art and science of, it's actually physician's art. I don't want to be romantic now, but the whole disappointment on a drug that is magic has reiterated the importance of a good physician, I think. And so maintain everything normal, as said before. If you do so, I think you have 95% of any ever possible effect in the benefit of the patient. Additionally, and as specific interventions, I'd like to propose not losing time. Don't stay in play unless very well justified. rather than scoop and run, and I'm thinking about thrombectomy, of course, in the event of objective intracranial hypertension. You have set a trigger and defined how you respond to that trigger. You can use hyperventilation and or osmodiuretics, or both. Hypothermia is justified in open heart surgery or CABG surgery and aortic surgery. No evidence, but reasoned approach and tradition, I should say, during cardiopulmonary bypass and hypoxia and perinatal hypoxia. The steroids during perifocal edema and meningitis. Nimodipine, only oral in aneurysmatic subarachnoid hemorrhage, and statins, we'll see. Thank you very much. Stay tuned.
Thank you, Christian, for your brilliant summary of what we can or what we should do to protect the brain. Any questions from the attendants to Christian, or any comments?
Thank you for a nice talk, Christian. So I have a specific question that relates to diabetics coming for neurosurgery. So in the Netherlands, like everywhere else, we have more obese patients and we have more diabetes. And then the patients also get steroids because they have a cerebral edema and the glucose control is poor. And then they get glucose and insulin infusion as part of the perioperative management. And they often then have a declining plasma sodium concentration and also poor glucose homeostasis. Anyway, I was wondering if you or other people have a solution for this problem. This, like with us, when we speak to our physicians, our endocrinologists, they are still stuck to this concept, especially in the insulin-dependent diabetics, that in the night before and during surgery they should get a glucose infusion with the insulin, and that's giving free water, and then you're disturbing their sodium and water hemostasis.
That's exactly the problem. The free water is potentially endorsing edema formation. We do use insulin and glucose combinations for treating hyperglycemia in non-neuro patients, and in fact have been supported by a most recent publication in anesthesia analgesia, actually, where they really were able to show, I think it's this month, that it was cardioprotective. So it was really improving myocardial function. I know we're talking brain here, but so the concept, I think, is valid, and it was just most recently supported by good evidence. Now, what we do in patients with neurodegeneration, this whole group that I was trying to look at, we omit the glucose. We play under ICU or intermediate care level conditions. We play with insulin only to see whether or not we get it controlled, either by bolus administrations, 8 units of insulin, to see what the response would be, and then a continuous drip in the absence of the glucose because of the free water. And I would think that as far as my own experience is concerned, or what we learn from those that adhere to this concept, which I think has a logical ductus, it works rather well. You can, however, adhere to glucose insulin if that's a situation prior to the ischemic or traumatic challenge. I would not think it's a big problem to do this the day prior to neurosurgery, because we still would have control of the patient in terms of a clinical access and so forth. But I would not feel well if the patient is in a sedative or anesthetized state, where we have no more access to the clinical consequences of it.
So you've taken the brave step of just giving the insulin. and
Right,
glucose.
right, in those patients. But other than that, again, just now, that insulin glucose concept for general organ function, particularly the heart, was supported by most recent data.
When we talk about normal whatever, normal pressure, yeah, yeah. Okay. When we talk about normal capnia, normal pressure, normoxia, normal whatever, we usually talk about healthy patients. The patients we have for brain protection are not always healthy. I mean, a patient who has high blood pressure in her normal life is not going to be, say, normal. So when you say normal, would you go for the normal parameters of a healthy person or for normal parameters for that patient in his or her normal life?
I think an individualized approach which would be more intelligent. Normal volemia, well, what is that? Okay, I'd say how is the patient, in what shape would be the patient prior to inductive anesthesia? That would be probably, to me, the corridor. And there you can see what's the CO2 with this patient at that moment. Is he hypercapnic or not? And then adjust it there. But I don't think that this is the question is important, but I don't think it's so important for normal capnia and normoxemia. If the patient is hypoxemic, I would not leave him hypoxemic just because he does well. I'd say he should be normoxemic. But if the patient is hyper or hypotensive, I'd say within 10% from that baseline range, I tried to manage. So it's a slightly individualized approach, and in some entities, such as with oxygen, I would not be too permissive, even if the patient shows up with an oxygen saturation of 94 pulse oximetry. I'd rather have him between 96 and 98.
Concerning to the ventilation and the idea to keep normal capnia, what do you think that would be the role for the prognosis of the patient? When we see when I see frequently after in the early period after extubation that we currently see that patients have hypoventilation. What do you think that would be the role of these patients submitted to a craniotomy if they have the first 1 hour, 2 hours after extubation of hyperventilation and hypercapnia? What do you think that it would increase the perilesion or the ischemia of the lesion? Do you think that as a role of that?
I'm not sure if I understand the question. Are you saying, do we have to deal with negative consequences post-operatively in the event that we intraoperatively hyperventilated? Was that the question?
No. I would say that usually we keep our patients under normal capnia during the intraoperative periods.
Yes.
But after extubation, we currently see the oxygenation with the oximeter, but we can't see the ventilation. And my question is, as I can't follow the ventilation, do you think that it would have some problems in the future for the patient if this patient hypoventilate and then have the increase of the CO2?
Yeah. Oh, I mean, obviously, that could well occur. That if post-operative vigilance goes down, and as a consequence, patients hypoventilate, and as a consequence, they get hypercapnic, and then they have increased ICP. That may well happen. At our institution, I think that is very much according to the European and also the AANA guidelines. We believe that every craniotomy patient deserves 24 hours of intermediate care, or even intensive care. So extubation on the table, if ever possible, is clear to get access to the clinical situation, neurological situation, but then not discharging him into a facility with low care rather than with care that also will be able to observe hypoventilation with secondary hypercapnia and ICP increases. So I think that's a question. The answer is you're right, and you need a structure to omit or avoid this.
Christian, is there any work been done on dexmedetomidine as a neuroprotective?
Yeah. Actually, Eberhard Kochs and myself and Bill Hoffman back in the early 90s did that in rats. The drug in our hands was extremely brain protective. Extremely brain protective. And I know we've been non-believers on smart thoughts issues, but I could understand, even I could understand that that might be a mitigating strategy if neurotoxicity in kids ever exists. But you've seen it in rodents and goat and everything. A lot of compounds that either reduce metabolism or, in the event of dexmedetomidine, reduce central sympathetic discharge, can reduce the extent of neuronal injury. I am not aware of studies that have proven that dexmedetomidine reduces infarct size or so. There is evidence that cognitive decline is a little bit less pronounced, that delirium may occur less, but then there's also studies that were not able to support this. But I believe that compound and the question of central sympathetic discharge is something to dig.
I'll have a provocative questions for you and for Emery. I don't want to focus the discussion around neuroanesthesia or anesthesia for neurological surgery, but I have these questions for you guys. And we have one neurosurgeon in the room now. During decades, before temporary clipping, we were giving huge bolus, for example, of thiopental, inducing birth suppression, with the idea that it was protective based on the physiology and coupling between flow and metabolism. But we know from some studies coming from Emory Group that birth suppression is a regional event. There are regions in the brain that birth suppression does not happen. And we also know that there are regional differences in the cerebral blood flow. So when we give a bolus of thiopental to induce birth suppression before the temporary clipping of the aneurysm, for example, we don't know what we are doing. Do you keep doing that in your patients or not?
We do, but again, hopefully a little bit distinguished. I would not, well, the basis, of course, is reducing cerebral metabolism. Again, although nobody has shown that that concept translates into clinical benefit, still do it. And there may be two situations, probably the gentleman from neurosurgery may support this or say I'm wrong, but there's two situations that you may want to have. One situation is sometimes neurosurgeons like, in the event of temporary clipping or definite clipping, they like low pressures to the extent that we give adenosine or hyperpacing to really have a 20-second, 30-second zero flow to the neck of the aneurysm, so that the topography, the architecture of the surgical approach is just ideal. In that event, the barbiturates are great because they reduce blood pressure and probably neck aneurysm pressure, makes it a little bit easier, facilitates the architecture of surgical approach, plus maybe some brain protection. But if not, you at least have the hypotension, which might be something the surgeon wants. And then there's a second class where you don't want this, actually where you probably want higher pressures, despite the fact that there's such a delicate aneurysm And in those patients, I say barbiturates, yes, but never drop blood pressure. So you need catecholamine support at the same time. But then you're just standing on this unlikely or likely metabolism leg. So that's how we do it.
I don't know. I don't do those cases.
Yeah, but from your point of view, it makes sense to do it?
I don't know.
Who's the gentleman from neurosurgery? Many. Sometimes in the German neurosurgical community, sometimes it's not evidence-based at all, but they propose to have cold water irrigation in the vicinity of the territory of this aneurysm. So I wonder if this is something in this country that you would support. Again, to be brain protective in terms of temperature effects. Cold water irrigation.
Just to give the perspective of a neurosurgeon, temporary crippling, we think about collateral circulation. So we want hypertension. Okay? This is temporary clipping because you want to isolate a segment, but you want to take advantage of all the collateral. The adenosine is usually used in basilar aneurysm in which you know that you haven't got much chances. If the clip is wrongly applied or you do something wrong, it's going to be a big amount of blood in the area. You're going to have zero visibility. That's why you are grateful for seconds of cardiac arrest that can help you to have less pressure in the neck of the aneurysm. But in the rest of the areas, we prefer hypertension because we use the collateral flow to perfuse the areas of the brain that we are going to leave without blood.
And about cool irrigation, are you using that? Cold water irrigation?
Cold water irrigation.
Just in a maybe absurd intention to cool the vicinity of the territory in danger.
Usually in awake craniotomies, when we stimulate the brain, because we know that we are going to induce seizures.
Right.
So if we use cold irrigation, in this moment, what happens is that, yes, we reduce the chance of seizures. And there is another interesting thing that you may know, is irrigating with mannitol. Not very many surgeons use it, but we use irrigation with mannitol when we want to reduce the size of the scar. Right. And let me explain why. Mannitol is a non-ionic, sorry, I'm among people that know more than that about me, a non-ionic product that so it doesn't spread the electricity so much. So we want to make coagulation in the brain stem, spinal cord, near acoustic, in areas in which we are afraid, because you have to remember that the coagulation has an area of damage. Then we irrigate with mannitol.
I didn't know that actually. It's good thinking. Thank you very much.
One question, Dr. Werner. What is your opinion about transfusion in neurological patients? What do you think is the best level of blood hemoglobin?
Oh, honestly, I don't know, and I really don't know. And it's ever changing between 7 and 9 and 6 and 8 and then maybe 11. I just don't know. I don't believe that there is a number that I can offer for the young or the old, for those with supravascular pathologies or those that may have a great vasculature yet have an oncological problem. I just don't know. We, in the event of brain oximetry, which we liberally do in our department, we would consider brain, now, if we have, for example, deoxygenation with an oximeter, we'd start along John Merkin's algorithm that was, however, proposed for cardiac patients, that you have a decrease in hemoglobin, a decrease in brain oxygen saturation as evidenced by neuroscopy. Then we start to increase blood pressure. If this doesn't work, we elevate inspiratory oxygen fraction. If that doesn't work, we consider hemoglobin and consider transfusion. He then also increased pump flow because it was restricted. His recommendation was restricted for cardiac surgery and cardiopulmonary bypass. But that would be an algorithm that then reduce hyperventilation, for example, is in this algorithm. So you work your way through this algorithm, ultimately may consider transfusion. And that's how we do it. Well, we don't say below 6, below 8, below 10 would be a threshold by which, by standard operating procedures, that's the trigger for transfusion. It's all a bouquet decision.
The question is because we are talking about normal, but normal in the case of hemoglobin is 12 or 14.
I agree with you. I agree with you. This is why it doesn't appear here. Yeah. I would think I'd apply what we learn for every other organ but the central nervous system, the evidence to the central nervous system, plus ideally monitoring of something of the brain to be more specific and sensitive in your decision whether or not you want to transfuse. But I'm not aware of studies that say outcome is better with a hemoglobin of 12 when compared to 8.
Just one more question.
I'm shifting from this region and asking something about, by introducing the new oral anticoagulants, did you change or introduce something particular when you get the traumatic subarachnoidal bleedings, or did you in any way change something? Because we are now much more obliged to procoagulate the patients apparently for the surgery.
You're talking about trauma or you're talking about elective neurosurgery?
I'm talking about trauma because for the elective we can somehow handle it.
Yeah, you could respond. Well, there is schools that say, well, there's fights on how early you would stop the anticoagulation in the elective event. So we're talking about trauma. Well, obviously, we work with two lines. One line is, funny enough, and I've underscored that, tranexam acid, which seems, I have never been an expert in this, but I'm learning from my own colleagues that this seems to work, and it's getting into guidelines now for trauma surgery, not yet for neurosurgery as far as I'm concerned. So that is one thing. And the other thing would be specific factor support, and I think it would be factor 5, 7, 10, and maybe 12. So you can use, if volume is adequate, fresh frozen plasma. If it's freshly available, just off the refrigerator, then you still have a lot of factor 5, which helps, and also factor 7. They are very sensitive and that decays within 30 minutes. Then after this, it's just the infectious albumin, you know. There's no more factors in there. But also factors that would go 10, 10A, obviously, and higher factors, specifically based on ROTEM.
So you routinely do the ROTEM?
Yeah, yes, we have
patients.
ROTEM. Yes, we have ROTEM available.
And let's say your ROTEM would be available within 40 minutes from the sampling?
Well, if it's a brain injury and you need to decompress whatever, scoop and run.
Go in,
yes. Scoop and run. And go for tranexamsäure and maybe PPSB or maybe PPSB, yes. Tranexamsäure, PPSB, wait for the ROTEM.
Okay, thank you.